Asmita, can I start?
Yes, sir. You can start.
Okay, so we'll start. So, good evening to all of you. I think this is the 150th session on this challenging case series. So, as usual, I will start with the short case first. Is my screen seen? Hello?
Yes,
Yeah. Oh, right. Just 1 minute. I'll just verify. Okay, this is the video is not there for this patient because she happens to be a doctor, so I did not took a video in this patient. I did not take a video in this patient. This is a story of a 22-year-old female. Her complaint started 8 weeks back with fever, cough, and diarrhea, which subsided with treatment over the next 4 days. 1 week later, she developed weakness of right lower limb, followed by weakness of right upper limb. 2 days later, she developed difficulty in climbing stairs, followed next day by loosening of the chappals from both feet. 3 days later, she noticed weakness also of the left upper limb and became bedridden. She developed dysphagia requiring laxative feeding towards the end of the course of the disease. So, in summary, over a period of 2 weeks, 10 days or so, she developed weakness of lower limb, upper limb, and difficulty in swallowing, preceded by history of fever and diarrhea about 1 week prior to that. That's in summary short case, no paresthesia in this case. Her peak deficit was after 1 week. She was investigated and put on IVIG with a gradual improvement and started walking. Dysphagia totally improved. But even after 6 weeks, her weakness was persisting in both lower limb, but much less than before, but still she could not get up from the sitting position or from the chair. And the main weakness was the postural muscles of right lower limb. There is no sensory complaints at any time. In examination, there is no wasting of any muscles. Power upper limb, she had weakness of distal muscles of both upper limbs about grade 4. Shoulder muscles and elbow muscles were grade 5. The lower limbs, in the right lower limb, right reflexes, hip extensions were of grade 2 power. Hip abduction grade 3, hip adduction grade 4. Right quadriceps, knee flexes, and distal muscles were about 4 to 4 plus. In the left lower limb, power was about grade 4 or throughout. So, in the upper limb, distal muscles were weak. In the both lower limb, in the right lower limb, proximal muscles were more weak than the distal muscles, mainly the hip flexes, extensors, and hip abductors. The lower limb, the power was about grade 4 throughout. All reflexes were intact, in fact, slightly brisk. Sensory system perfectly normal. So, clinical diagnosis was GPS, and the NCS was taken on the 4th day of illness. This is the NCS. This is the right median. You can find there is a decrease in the amplitude at the elbow and above elbow compared to the distal amplitude. Distal amplitude is 24 millivolt, whereas it is 7 on the proximal part. This is the wave pattern seen in the right median. You can clearly make out the drop in the amplitude in the elbow and above elbow region. This is the right median, axilla and elbow. Again, the waveform can see here. This is the ulnar, on the right ulnar. There is again drop in the amplitude 2.55 compared to 13 in the distal stimulation. Same with the left ulnar. There is a marked drop in the amplitude 1.6 compared to the distal amplitude. And this is the wave pattern in the ulnar. The first is at wrist, second one below elbow, third above elbow, and fourth in the Epps point. So this is left ulnar. Again, there is a drop in the amplitude on the proximal stimulation above elbow and Erb's point compared to the distal stimulation. Radial, only 2 points are stimulated. That is normal. This is amplitude radial stimulation. Come to the lower limb, there was no apparent abnormality in the lower limb because the distal latency, velocity, the amplitude was normal in both proximal and distal stimulation. This is the motor conduction, both tibial and conperoneal. Come to the snaps are entirely normal. Look at the snaps in the right median 86, left median 174, right ulnar normal, left ulnar also normal. Radial snap is also normal. Right superficial peroneal, left peroneal, subperoneal, right sural, left sural, all normal. FF latency is also within normal limits. You can find out the FF latency of 25, 23, 30, and 25. This is conperoneal FF latency, again within normal limits. Less than 50 all throughout. The H reflexor also have got a normal latency. This is a summary. So, what do you think the patient must have had? Straightforward, simple case, straightforward.
How are the planters?
Pardon? Plantar was flexor.
Demyelinating neuropathy, sir.
Yeah, demyelinating neuropathy. Okay. So, just one more minute. Are you able to hear me now?
Yes, sir.
Yeah, okay. My speaker is not working. Anyway. Okay, plantar. Okay, what demyelinating neuropathy? Any other thoughts? Any other differential diagnosis you want to keep?
Sir, mononeuritis multiplex.
Pardon?
Mononeuritis multiplex.
In fact, no. I was not able to hear you well. Just 1 minute. I'll change my speaker and then find out. Just 1 minute. Can you tell me now? Hello? Am I audible?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Okay. Okay. Now, can you tell me your doubt, please? Query. Can you repeat your query, please?
In spite of 8 weeks, the dependent reflexes are brisk.
Yeah, right. I saw the patient only after 8 weeks. Still reflex happens to be brisk. Well elicited.
And there's no there are no features of nerve involvement on the lower limb conduction. It was completely normal.
Completely normal, correct.
So it's maybe not just neuropathy. Could be wondering whether it's an associated myopathy also in the lower limbs.
Okay, right. That possibility cannot be, but totally asymmetrical, preceded by diarrhea. And okay, that's a possibility one cannot rule out.
Sir, it looks like GBS axonal variant.
If it is a myopathy, why do you expect a conduction block in that NCS?
That's what I said. Could be because lower limbs are completely normal. No, the conduction is completely normal.
Yeah, why it is normal? Because their affection the lower limb is predominantly proximal.
Proximal conduction block.
No. Proximal muscles were affected because reflexes, hip extension are more weak. Distal muscles were a gate for plus power. So usually what we check is a conperoneal and tibial nerves. No, we are not usually checking the femoral nerve or other things. So there you won't get any conduction abnormality if the proximal muscles were the predominantly affected one. That may be the explanation why the conduction seems to be normal in the lower limb.
Axonal
In the upper limbs, sir, there is more distal involvement than that of proximal.
Exactly.
And
That
where
is
in
where
the
abnormality
lower limb proximal involvement more than the distal.
Correct. That is why the disparity in the conduction what Joy was pointing out.
That is the reason for that. So, and 8 weeks have already elapsed.
Yeah, correct.
So,
And the FAs are also normal, no?
CIDP may be one of them.
Yeah.
FAs are also normal, no?
Yes,
No,
yes.
FAs are all normal. No, in fact, the peak deficit was 1 week, but afterwards, no worsening. So we can't call it as a CADP because the evolution has completed over a period of 1 to 2 weeks. After that, there is no progression.
So
So
it
this
should be
conduction
variant of
block,
GD.
There is a
sir,
conduction.
so we can consider a nodoparanodopathy.
Okay, right. What do you think? Is it ADP, Aman, or nodopathy? What do you think the patient is having?
So one thing, breast reflexes, Aman with reversible conduction failure, that one. But the lower
Okay.
limbs, there is no conduction block. If this is much more proximal. So nodoparanodopathy can have proximal involvement, such as neurophasin antibody, something of
Yeah,
that sort.
look, even Aman or ADP, all can have a proximal involvement more than the distant. So that's a classical presentation, but that will not help to differentiate the thing. It is electrophysiology which is going to help us.
Sir, there is a conduction block without temporal dispersion.
Correct.
That points towards nodopathy, paranodopathy, sir.
Okay, very good. So let us see. Let us say a conduction block, decrease the amplitude by more than 50%. So this is the conduction which I already shown before, right? So ADP is the one which you usually keep in mind when the person becoming like that. But the question is it ADP? Could be a focal demyelination, the segment at the elbow can produce a conduction block. But what is odd again is a typical ADP is that I'll tell you what is odd again. It's already been mentioned here in one of the doctors have mentioned it. The second NCS was done after 1 month. That's when she came to me and did the second NCS. This is second NCS. See, the amplitude drop is so much decrease in the amplitude in both median, ulnar almost 0.1, and both ulnars are dorsally decreased. Peroneal is also decreased. Initially, it was suitable. And the right tibial was also decreased. This is sensory conduction, again normal after 1 month. FAV latency could not be obtained in these nerves because the amplitude is very low. So you will not get FAV latency, FAVs. Whatever available FAV is within normal limits. So what is the diagnosis now?
So can it be axonal variant of GBS caused by Campylobacter?
Axonal GBS, why should you put is a conduction block?
Is there a conduction block now?
There's no, where the amplitude has become grossly decreased. See, I can show the NCS parameter once again. This is NCS now.
There was conduction block only in the first conduction, no?
Yeah, correct.
Demyelinating with secondary axonal.
Demyelinating going to axonal. Okay. In fact, this topic I discussed some time back when somebody wanted me to talk about nodopathy and paranodopathies. So I'll explain once again. Come to that. Okay. The clinical picture says now axonal degeneration. In the present picture says you have an axonal involvement, Aman writing. Now the question is it an ADP or Aman? The question I asked before, what is again is typical ADP is that distal latency and conduction velocity are normal. With conduction block there is no prolonged distal latency or conduction velocity. That makes ADP less likely. A pure focal demyelination occurring in the nerves is very uncommon in an ADP. And there is no dispersal potential, which you have to see for the waveform. You can see the waveform here. Let us see the waveform, the one which I have shown before. So there is a conduction block, but there is no dispersion of the potential. The duration is same. Okay, so again, that makes an ADP unlikely in this patient. Now, what is the diagnosis now? I'll explain it in detail. This is classically a nodopathy with subsequent axonal degeneration. The nodopathy can be due to can have an evolution in 2 ways. One is reversible conduction block. with the patient recovers totally, or the amplitude comes back again. The second one is the axon can go into degeneration in the distal to the nodal involvement. I will explain it a little more. Now, let's a brief review of the nodal affection. It can cause a reversible conduction block, that is reversible conduction slowing or a block mimicking demyelination, but without temporal dispersion. The nodopathy can also cause axonal degeneration. Let us explain one by one. So this is the classical with the reversible conduction block. Suppose there is a conduction block there due to a nodal involvement. We are going to get is a decrease in the amplitude and the proximal stimulation compared to the distal stimulation. The classical conduction block. When there is a rapid recovery, because the antibodies which has affected the sodium channels have recovered, the node has become functional again. So what will happen? The amplitude comes back. So there is a conduction block disappears. That is what is happening in a reversible conduction block due to nodal involvement. If the nodal block happens to be distal to the distal stimulation, like this, what you're going to get is a decreased CMAP amplitude on proximal distal stimulation. So apparently there is no conduction block electrophysiologically, but actually there is a conduction block which is seen as low amplitude only because the involvement is distal to the distal stimulation. This is also a conduction block, but mimics an axonal involvement because amplitude, CMAP amplitude is decreased both proximal distal stimulation. Okay, so this also, but the distal conduction. So what happened? The patient recovers on follow-up, that block disappears and the amplitude becomes normal. So you can have an apparent amine-like presentation, the low amplitude, but on subsequent electrophysiological changes, you find the amplitude picks up, telling you that it is a reversible conduction. Now let us see the second consequence of nodal affection, that is axonal degeneration. See what happens is the node is affected here, and distal to that, see if the destruction of the node is severe, all sodium channels have been destroyed. It is as if that part of axon is dysfunctional or cut. That axon is not transmitting alone or dysfunctional. So what will happen when the axon is damaged? The subsequently distal to the axon get degenerates like this. So let us see what is happening here. There is initial nodopathy there, but that nodopathy did not recover. So what is going to happen is the distal part of the axon degenerates. So what will happen? The amplitude becomes low on proximal and distal stimulation. Wherever you stimulate, the amplitude will be low. It mimics something like a pure axon degeneration. But the initial picture was like a conduction block as seen here, but subsequent picture becomes that of a axonal involvement. That is exactly what has happened in our patient. Initially, there is a conduction block, subsequently in axonal degeneration. What is the clue is that if it had been, the conduction block had been due to a demyelinating neuropathy, you expect three other things. Either conduction velocity is prolonged, or distal valency is prolonged, or there can be a dispersion of the potential should be there. So only follow-up EDS can differentiate whether the initial affection of the node is reversible one, or will lead on to an axonal degeneration. So the amine with reversible conduction failure, the conduction resolves rapidly, leading to increase the distal amplitude in 2 to 5 weeks without excessive temporal dispersion, spontaneous activity in the EMG, or change in the MEP morphology. So absence of temporal dispersion, change in the MEP morphology helps differentiate it from AADP, that is conduction block with temporal dispersion. AADP with conduction, that is conduction block with temporal dispersion. The rapid reversibility in absence of spontaneous activity in the EMG helps differentiate from amine type of GPS, that is the pure axonal degeneration. That is how you differentiate from reversible conduction block from that to AADP and that from the axonal type. This is the one with classical conduction failure. You get a decrease in amplitude, but it picks up on subsequent this thing without any dispersion. prolongation of distal latency, and dispersion of the potential. If you look at the Aman with axonal degeneration, it's a length-dependent conduction failure occur. The abnormal ambient reduction of the proximal CMAP due to conduction block at the proximal nerve segment. With serial recordings, it progresses to distal reduction of the CMAP amplitude due to distal Wallerian degeneration. And this is associated with poor prognosis, like which I already shown before. This is initial affection, subsequently the subsequent axon degenerates. So initially you find a conduction block here, but subsequently that all amplitude becomes low. It is not reversed because the distal part is degenerated, mimicking an axonal, pure axonal degeneration. These are the various types of electrofield parameters. This is a classical AADP. You find a conduction block with a dispersed potential. In the case of Aman with conduction block, that is reversible one, which improves without temporal dispersion. That's in the case of Aman with conduction block between the proximal and distal stimulation. If it happens to be distal to the distal stimulation, the block happens to be in that location, you can have distal low CMAP amplitude to begin with, and subsequently it picks up. Again, reversible conduction block. But all the time it improves without temporal dispersion. And this is the Aman with axon degeneration. At post-sound, it becomes progressively low because of the subsequent axon degeneration. So that is regarding the case. So any questions in that you can ask. Is it clear to you?
Sir, one doubt.
Yeah, please.
Hello, sir. Am I audible?
Yeah, I can hear you. Please ask.
Sir, in a case of, yes, sir. Sir, if it is a non-ordinary, for example, if you are considering mononeuritis multiplex and you have a vasculitis, and the
Correct.
vasculitis is causing an axonal loss, you will get the
Correct.
same sort of pseudoconduction block picture,
Yeah,
which later
yeah,
on looks like an axonal loss.
Yeah, perfectly right. That what is it is
So-
correct. So it can in a vasculitis, if you do it in the initial 7 to 10 days time, you can get a pseudoconduction block. But if you do it after 10 days, you will not get that thing. The amplitude drops will occur. The distal
sir,
part will
can we
degenerate.
find, like where exactly the location on the axon, like how do we know whether it is a nodopathy, a paranodopathy? Because it will be presenting the same way as an ischemia, which is causing an axonal loss. So what helps you differentiate?
If your point is very well taken, that'll be very, very difficult to differentiate the two. Whether it is an subsequent axonal degeneration due to vasculopathy, focal lesion or not. That will be difficult to differentiate. That mimics a axonal involvement, focal axonal loss, like a vasculopathy affecting that particular segment.
Okay, sir.
Can you hear me? Hello, can you hear
Yes,
me?
sir. Yes,
Yes.
sir.
Yes, sir. We can.
Yeah, there's some problem came in between. Okay, can you see my slides now?
No, sir.
No.
Okay, no, I have to share it again. Just 1 minute. Just 1 minute. Just 1 minute. Is it seen now?
Yes.
Yes, sir.
Yeah. So what your question is very, very valid question. This all it means that it should be a focal lesion. If it's a focal lesion that is destroyed the axon, whether due to ischemia or due to a condition like a nodopathy, it behaves the same. It is as if that particular nerve is cut at that point. Then it cannot differentiate the two. But here the temporal course and the clinical history favors a GBS-like pattern, because you've got a diarrhea following which acute onset progressed over a period of 1 week, affecting all the 4 limbs, and then started improving. So that pattern is like not like a vasculitis. Otherwise, electrophysiologically, it would be difficult to differentiate.
Sir,
But-
CSF was done or anything? CSF that out
This
of
way-
curiosity was
Yeah, the
CSF albuminous
CSF
cytology.
was normal. CSF was normal.
Okay, sir. So this is Aman with axonal degeneration.
Aman with axonal degeneration.
Okay.
So is Aman and nodopathy the same?
No, one of the explanations for the Aman with the Aman is nodopathy itself. Because the nodal affection can have 2 phenomena which I already told. One is axonal degeneration. Then you can have nodopathy without nodopathy, axonal degeneration also in Aman.
So in this patient is Aman or is it nodopathy?
So one of the pathophysiology of Aman is nodopathy. Some people say all the Aman are now should be called as nodopathy. I do not know. But whatever it is, the previously so-called axonal type of GBS were now called as nodopathies. It comes under the category of nodopathy, which is subsequent axonal degeneration.
Sir, if you have seen this patient after the first NCV, you could have done biopsy, sir, nerve biopsy or not, sir?
And after the first NCS?
If you have seen this patient for the first instance, whether you could have, we have considered nerve biopsy or not, sir, to differentiate
not at all.
between vasculitis.
No, nerve biopsies indicate only very, very selected instances. For example, one such instance is Hansen disease is important. Then vasculitis you can do for this thing. Then infiltrated lesion like sarcod, amyloid. On those situations we can do. Otherwise, biopsy has got not much of a role. For demyelinating disease and axonopathy, I mean, nobody does NCS, nerve biopsy. It's not required. That's why. We are not going to get benefit from doing nerve biopsy.
Okay.
Sir, if these patients are treated with rituximab, do we need to repeat the doses of rituximab as we do in other types of demyelination?
No, if it is a reversible one, you can give only 1 dose. That's not what is required. The antibody happens to persist for long, then we have to repeat it. It all depends upon the titer of the antibody, which is the pathophysiologic mechanism. In fact, we do not know much about a clear answer to your question will not be available because we are only acquiring knowledge about the new antibodies in GBS and CADP, etc. Like you have a neurophage antibody, whether they are going to persist there, will disappear with treatment or we do not know. The antibody happens to persist, then we have to continue rituximab.
Does this patient require rituximab? Is this AADP or
No. This patient was given only IVIG. It's only incomplete recovery. That recovery will take some time there is no role for rituximab or subsequent IVIG in this patient. Because patient is not progressing and there is no relapse also.
Sir, how will be the tendon reflex in nodopathy?
Pardon?
In tendon reflexes in nodopathy.
Even in Aman type or in DMLA type, you can have retained reflexes. There are some explanations are very funny. Some people say that associated cord involvement. That explanation one is there, but nobody knows. But I have seen classical AADP, DMLA with reflexes. Seen Aman with reflexes. I have also shown one case before with typical Aman with brisk reflexes. Brisk reflexes, not well elicitable, brisk reflexes.
that's a boy, no?
That's a boy. Why you remember that? mimicking something like a spasticity and a pyramidal lesion.
But in nodopathy, it should be reduced.
No, theoretically, it should be reduced. But you see electrophysiologically what is happening now. See, I have seen this patient after 1 month with an absent potential or hardly any LCD potentials. The reflexes are well elicited.
I initially thought the first nerve condition you showed is the recent one.
No, that is the first one.
If you had the first one as recent, what did you think?
If you had seen the first one, the conduction block as a demyelinating type or the other thing, nodopathy, but in the absence of any prolonged distal latency or in the absence of any dispersed potential, the absence of any conduction velocity prolongation, I would have considered nodopathy from the very beginning.
No, if it's after 8 weeks, if you get the same thing as the first one. That's unusual, no?
That's unusual. The second one is not after 8 weeks. Second one was after 8 weeks. The one which was the low CMAP amplitude.
The first one was after 8 weeks. It's very unusual in the lower limbs. No, it can't happen, no? Can we get the first conduction? You do it after 8 weeks. Can you get the same as the lower limbs? It was completely normal, no? Can you get that after 8 weeks?
Yes, you can get it. Because the time for the recovery for the nodopathy reversible can take a long time. Sometimes it may not be weeks, it may be even months.
So the first choice is methylprednisolone. In case of nodal block is reversible.
No, the first thing is our usual treatment for any GBS, IVIG or plasmapheresis.
But they say that for reversible this nodopathy, reversible nodopathy, IV methylprednisolone works well.
No, I don't know because I not say I showed some time back one boy who had GBS like presentation with severe pain. That idea gave IVIG did not improve. Put the patient on IV methylprednisolone, patient improved remarkably well. I showed that patient, my child also. So whether that's a usual pattern, I think we cannot say like that. Usually, it's a classical dictum is you give IVIG or plasmapheresis. In rare cases, if it does not work, you can try IVIG. I'm not against or anything like IVIG. I have tried many patients with IVIG with good improvement, especially those with GBS with pain. The pain subsides remarkably with first dose of IV methylprednisolone. But the literature does not support that very much. Some would say if you give IVIG is contraindicated in GB, that's also people say like.
Only one dose is needed, IVIG.
IVIG usually give for 5 days, no? The usual 2 gram per kg body weight spread over 5 days. Okay, shall I go to the next case?
Yes, sir.
Okay. This is also a little long case. This is a story of it's a common problem which often which you come across in your practice. This is a story of a 34-year-old man. He was under my treatment for cervical IVDP and was advised bed rest for 10 days. After 9 days of bed rest, he developed positional vertigo on turning to either side. This is the video of the patient. See, initially, in fact, I started taking the video after the first two, after a few seconds, because I had to, by the time I took the mobile, my mobile on, the vertigo subsided the initial part, but still you can find the abnormality. Made the patient lie down on the cot. Initially, he had vertigo, now there is no vertigo. There is no nystagmus. To the right side, he said there is dizziness, but very hardly a few beats of nystagmus. Turning to the left side, you can see what is happening. You can see left beating nystagmus. This is on keeping a patient lying on the left side, I put my mobile phone on the same side. That is, it appears as straight. It's not supine. He's lying on the left side. Goes on beating to the left side and stops. Now I'm making it straight supine again. Straight supine again. I'm turning to the right side now. Now it beats to the right side, but much less than before. Again, back to supine position, straight ahead, lying flat on the ground, flat on the coat. There is no nystagmus. Now putting again on the left side, the previous position will produce maximum nystagmus. This on the left side, I can start beating to the left side. Then again put straight back, supine position. Now look what happened, beats the contralateral side. This is supine position, not on one side. Straight supine beating to the right side. Just not there before. It subsides. Again turning to the right side. No nystagmus. Initially had a few beats, now it's no nystagmus. Again back to the supine position. No nystagmus. Again turning to the left side, the previous offending position. Nystagmus reappears again with beating towards left side, but less than before. In straight ahead again. It beats to the right side. Then get up from the coat. There is no nystagmus. And put back, lying down on the coat, it beats to the right side. Straight putting back supine, again beats to the right side. Few beats. Beating to the right side. So if you want me to show the video once, I can show. So what did you observe? I'll tell you what all things you observed. On lying down flat on the bed in supine position, he had vertigo, which is not shown here because I told before it took some time for me to switch on my mobile. On lying to the right side, he had mild vertigo with nystagmus beating to the right. Again, not picked up well in the video since by the time switched on the mobile, it had become less. On returning to the straight head supine position, there was no nystagmus and vertigo. On turning the head to the left, there was a strong left beating nystagmus with severe vertigo. On bringing back the head in the straight ahead supine position, there was right beating nystagmus with vertigo, which subsided after some time. On turning the head to the right side again, there was no nystagmus. Returning to the supine position again, no nystagmus from the right to the supine position. Turning the head to the left again, there was nystagmus beating to the left. Returning to the supine position, there was mild right beating nystagmus. On making the patient sit up, there was no nystagmus. Making him lie down again, the supine position, there was right beating nystagmus. This is what you have observed. So if you want me to show the video once again, I can show. Otherwise, you can tell what could be the problem in this patient.
Left lateral canal lithiasis.
Okay, left lateral canal lithiasis. Perfectly right. Right. Anyone else have a different opinion?
The problem is
Okay.
you get the nystagmus while lying down supine, not by
Correct.
the side.
Right. Here's so what he said is what which told is correct. But on canal lithiasis, horizontal canal lithiasis, there is a geotropic nystagmus that is on lying on the left side nystagmus beats towards the left side. On lying on the right side, nystagmus beats to the right side. That's what you observe. Other point is that here, on turning from the left side to the straight supine position, there is a right beating nystagmus. And also, when the patient is lying down from the sitting position, just lying straight backward, has got a right beating nystagmus. Okay, so I think sometime back I talked about this BPPV. So I think I will tell the physiology once again, so that make you understand why this right beating, etc. is occurring. So what ask you are told left horizontal canal BPPV geotropic. Then why is that he had right beating nystagmus and bringing his head in supine position on the left side? The question which Joy has asked. Before that, I just you may most of you know about this physiology, but still for at least for the beginners, I'll repeat what I will or the basic physiology once again, a little bit. In the vestibular physiology, this is hair cells are in the ampulla of the semicircular canal. It is the deflection of the ampulla which is the stimulatory for the sense of rotation. The hair cells are stimulated by the endolymph fluid motion, which pushes the cupola. It can be towards the ampulla, as is shown here, or away from the ampulla, depending upon the direction of the endolymph flow. The flow is towards the ampulla, it's shifted to the other side. If it is away, it's shifted to the same side. Now, if the hair cells, they've got a kinocilium and the stereocilium, whatever it is, the long one is the kinocilium. When the hair cells shift towards the kinocilium, as shown here, that canal gets stimulated. When the hair cells shift away from the kinocilium, that canal gets inhibited. That's the basic function of the receptor, the hair cells in the cupola. The arrangement of the hair cells in the cupola is different in the horizontal and vertical canals. In the horizontal canal, the orientation of the kinocilium in such a way that when the endolymph moves towards the ampulla, that canal gets stimulated. What is called a centripetal flow. That is a stimulatory for your horizontal canal. In the case of vertical canal, when the flow is away from the cupola, that canal gets stimulated. That is a centrifugal flow. So in horizontal canal, when the flow is towards the ampulla, that's stimulated. In vertical canals, both anterior and posterior, the flow is away from the cupola, that canal is stimulated. This again shown here. When it flows towards one, that is stimulatory, and it is away from the superior inferior, that is stimulatory. Now, the endolymph flow is opposite the head rotation. Suppose if you've got a trough full of water and you put a paper boat on the top, if you pull the tray forward, the flow, the fluid will go backward. You'll see the boat going backward. Something similar to that. See, this is the semicircular canal. This is a utricle and this is the canal. Suppose your patient is lying flat and you're looking from behind. This is the horizontal canal, which is vertical. If you rotate the head like this, that is the counterclockwise fashion. When the head begins to rotate, the membranous and the bony labyrinth moves along with that. However, the endolymph, because its inertia, lags behind the surrounding membranous labyrinth, just rotating within the canal in the direction opposite to that of the head. It moves the opposite direction. So when you move the head in counterclockwise fashion, fluid moves clockwise and vice versa. That is the physiology, the fluid motion occurring in the canal. For example, when this is the head, which is, you are viewing the head from behind. Patient is lying supine with the leg down, and you are behind you are the head. So here the left side is the left side, right is on the right side. So you're moving the head towards left side. That is from the anti-clockwise direction. When the head is turned to the left in the horizontal plane like this, the flow in the horizontal canal is the opposite side clockwise. This is the orientation of the canal in the left and right. This is the left horizontal canal, this is the right horizontal canal. So fluid will be opposite in the direction, to the clockwise direction. The fluid motion is clockwise. See what is happening now. On the left side, the fluid is moving towards the ampulla. So the original canal is told before, when the flow is towards the ampulla, that gets stimulated. On the right side, what happened? The fluid is away from the ampulla because its fluid is moving in a clockwise direction. So right one get inhibited. So normal physiology, when the fluid is moving towards the corresponding ampulla, it is stimulated. When it is moving away, that is stimulated. Okay, this is what is the normal physiology. When you get one side is stimulated, when you move the head in one direction, one horizontal canal is stimulated, other is naturally inhibited, that particular position. But this is not what is happening in BPP because the abnormality is only in one canal. So stimulation is occurring on one canal or inhibition is occurring only one canal. So this is what is so place away the ampulla that gets stimulated. Now canal lithiasis is what? The degenerated orthogonal debris detaches from the utricular matrix and inappropriately enters one of the three semicircular canals, namely posterior, horizontal, anterior. The most common is posterior, then horizontal, and least anterior. Most commonly, the debris enters the posterior semicircular canal, followed by the horizontal canal, and least in the anterior semicircular. In cupulolithiasis, what is happening is that the orthogonal debris becomes attached to the cupula. It does not depend upon the fluid motion. The cupola becomes more weighted because the particle get attached to the cupola. It becomes what is called heavy cupola. It becomes more heavier than the fluid, making it heavy and gravity sensitive. Whenever it's heavy, it can gravity sensitive. I think CUPSI and this thing I will skip. So these are the various types. One is this is horizontal canal, where the particle can lie in the posterior non-ambulatory portion. That is the commonest one. Then one is the anterior ambulatory portion of canal lithiasis. That is less common. And this is the cupulolithiasis, where the particle get attached to the cupola. So I've talked, what we need to remember is the posterior one, which is the most common one. That is a cupulolithiasis. Canal lithiasis is posterior and anterior, free-flowing particles in the canal. So the deflection of cupola is determined by the direction of flow of the endoleaf in the case of canal lithiasis, and position of the ampulla in relation to gravity in the case of cupulolithiasis, because it is a fluid motion, because the free-flowing particle inside determines the deflection of the cupola in the canal lithiasis, because the particles are within the canal. On the other hand, in the case of cupulolithiasis, the cupola become weighted because the particle attachment. So it depends upon the gravity, in which direction it is, only because it is not dependent upon the fluid motion. So in canal, when the head moves, the disloyed orthoconia moves inside the canal, resulting in fluid motion. The deflection of the cupola is the direction of the fluid motion, which is opposite of the movement of the head, which already told. In cupulolithiasis, the cupola shifts the direction of gravity because it becomes weighted. Now let us see this particular patient. We are talking about, I'm only talking about the posterior non-ambulatory report now. This is the posterior and it's already told. Now imagine you are viewing the patient from patient lying supine. In the supine position, what happens? The horizontal canal becomes vertical. This is the horizontal canal. And this is the ambulatory portion, which is the uppermost here. Okay. This is where the receptor, this is the particle lying on the posterior ambulatory portion, the usual situation. When you turn the head to the right side, patient is asked to lie on the right side. What will happen? The head is turned in the clockwise direction. But the fluid motion is counterclockwise, the opposite like this. When it's turned like the fluid will come towards that. So this particle will move towards the ampulla. The ampulla, the horizontal canal is placed anteriorly here. When you lie supine, the horizontal canal becomes vertical. What happens when it rotates to the right side? When it rotates to the right side, the flow is counterclockwise towards the ampulla, that is gets stimulated. So for example, when you turn the head to the right, the fluid motion is opposite. Fluid and the cupola and stimulate the cupola. Again, I will show one more diagram, which these are all made yesterday. So this is the normal position of the lying supine. Okay, this is the cupola here. This is the particle. When the patient is turning to the right side here, this particle moves forward. and the particle come to this position. Okay, the dependent position, and the fluid motion is towards the ampulla that gets stimulated. This is another picture showing the same thing, because when you turn the head to right side, the particles will move towards the ambulary portion, get stimulating it. So let's see, the right gets stimulated. Now we know the right canal is getting stimulated. What happened if the right canal is stimulated? The right is the right one. Here, the right is on the right side here. It stimulates the vestibular nucleus and go to the opposite abducens nuclear complex and produces stimulate the contralateral mountain gate center or abducens nucleus. So it produces, the eyes deviate to the left side in a slow fashion. So it will produce a slow component. Remember, always a pathological component is a slow component. When it stimulates, it shifts the eye towards the opposite side. Here, when the right is stimulated, it's towards the left side. And the corrective component is to the right. So when the right canal is stimulated by the particle, the nystagmus is to the right side. That is, when the patient lies on the right side, that canal is stimulated, you get a right beating nystagmus. Actually, the pathological component is a slow component beaten to the left side, but what you observe is the fast component, or nystagmus is named according to the first component. It beats toward the side of movement. To the right means to the right. That is why you get the ipsilateral nystagmus in the case of the stimulation on the same canal, horizontal canal. So nystagmus beats the right side towards the ground when you turn the head to the right side. So when you lie on the left, so what happens when the patient lies on the left side? The fluid motion towards the opposite in the right canal, away from the ampulla, and cupula deviates away from the ampulla. Just like I told before, when the patient lies on the left side, you can remember the particle is on the right side, not on the left. Right is the abnormal one. So you can stimulate. The same patient, you turn the patient to the left side. What will happen? The fluid motion is now opposite. So the fluid is moving away from the right side. Opposite the right canal, that is away from the ampulla, that canal, the right ampulla gets inhibited. This means that nystagmus is now beats to the left side. So when right is stimulated, naturally right beat nystagmus. When that is inhibited, you get nystagmus left side. So what will happen when the patient lies on the left side? Nystagmus again beats to the left side. That is side of movement. So that is what called geotropic type. So when the right canal, now let's see this one. What happens when the patient rotates the left side? I'm rotating to the left side now. What's happened? The particle now moves away from the cupula because the direction of motion of the fluid is opposite the movement of the rotation. To the left side, the flow is clockwise, away from the ampulla, that side is inhibited. When you lie on the left side, the fluid motion is towards the opposite side in the right canal, away from the ampulla, deviates from them. Same thing which I told. Now its right side is inhibited. So the stimulation is gone on the right side. Then the left will be overacting. And you get slow deviation towards the right side and fast component to the left side. So when right is inhibited, you get a left beating nystagmus. Okay, when right is stimulated, you get a right beating nystagmus. Okay, so when you lie on the left side, the right is inhibited. When the right on the right side, right gets stimulated. That is why you get a direction changing nystagmus on turning the side. So in effect, it becomes a geotrope. In whichever direction you turn the head, nystagmus must be to the same direction. Now, but this is the same thing we told. And when the patient lies on the right side, nystagmus must be to the right side. The patient lies on the left, nystagmus must be to the left side. And see, this is called geotropic nystagmus. Now let us see about the cupulolithiasis. In cupulolithiasis, the particles get attached to the cupula. So imagine a right horizontal canal cupulolithiasis. What happens if the patient is shifting to the right side? See here what happened. This particle is attached to the cupula. This is attached to the cupula. Particle is attached. When you turn there to the right side, that becomes heavy. That shifts away from them. So this is the ampular direction. the cupula dips away from the ampulla. So what will happen? That canal is inhibited. So when you turn the head to the right side, in cupulolithiasis, that canal gets inhibited. That means, as told before, you get a nystagmus beating to the opposite side. So what will you get? Cupula deviates away from the ampulla. Right dorsal canal is inhibited, similar to vertical left canal is stimulated. Nystagmus beats away from the ground for apogeotropic type. Apogeotropic means away from the ground. So I think I'll skip the two types of canalithiasis. I will skip. I'm more confused. And ambulatory type, I'll skip that. Now, this is the question which I was asking earlier. Why is that there is horizontal opposite beating nystagmus? In our patient to the right, he had maximum nystagmus turning to the left side. On bringing me to the primary position or superimplicitly beating to the opposite side, even without turning to the right side. Now let us see the same in the patient I had. Now he had got a right-sided cupulolithia. This is the position where you turn the head to the right side. Now our patient turning to the right side now. Our patient is left side. Here in the picture I am showing on the right side. This is the position of the particles now fallen down to the gravity position. So now turning back to the supine now, actually the previous picture I shown. Now it has become supine. So what will happen? The flow is opposite. So it has become the primary, the particle will move away from the cupula. See, this is the turning to the right side. I'll show the picture once again. This is the one. It is turning to the left side. The fluid motion is away from the ambulatory region. The particle become now, so this will get inhibited. So that is why you get nystagmus beating to the right side on returning back from to the supine position, because the flow is away from the ambulatory region. That answers Joyce's question, why there is a right beating nystagmus on turning from left to the right, left to the supine position. The fluid motion now reverses.
So that should happen in every canalithiasis, no?
Yeah, every canalithiasis, this should actually happen. But sometimes if you're doing it in a slow motion, moving turn back, you may not get that. Okay, subsided and turning the head slowly to the supine position, you may not get this. Rapid movement will produce this kind of a change in the fluid motion. It all depends on how fast you're moving the head. There is also one more explanation, which I will explain now itself. Now, one of the simple bedside technique to find out which side is affected. And before that, you must know which side is affected, because the maneuver you do, or the Guffonis maneuver or whatever, or you find the barbecue maneuver, whatever it is, you must know the side. Then you turn the head position of the head and do the maneuver. So usually in canalithiasis, the side where you get a maximum nystagmus is the side of affection. In cupulolithiasis or apogeotropic type, the side with the less affected is the side of affection. But sometimes, you cannot find which is side more amplitude, less amplitude, difficult. Sometimes I find here it is very simple. On turning left side is very gross nystagmus. On turning the right side, very minimal. You can know it's clearly on the left side. Sometimes you may not find such a gross difference. In that case, the best thing is to do the lying down test. Simple. Just ask the patient to sit on the cot and straight lie down on the back. Look for the nystagmus. The nystagmus is between the normal side in canalithiasis, which is the affected side in cupulolith. I will explain that thing. See, normally the horizontal canal is tilted 30 degrees up. It's not, horizontal canal is not exactly horizontal. It is slightly 30 degrees up, like the airplane leaf. So it's pitched forward by 30 degrees. The canal is horizontal with no incline and nystagmus disappears. So when you move the head 30 degrees down like this, then the canal is perfectly horizontal. Okay. In that position, there is no fluid motion within the canal. Suppose when you straight head like this, head is straight like this is the normal position of the 30 degrees. As the lateral canal is oriented with the ambulary and elevated at 30 degrees above the horizontal, when the head is in the upright position, there can be a slow movement. That when what will happen? The anterior part is the ambulary portion. The slow movement of the particle away from the ampulla. Because the posterior part is dependent, this is uppermost. Because head is straight. Since the otoconia gravitates away from the cupola, the canal gets inhibited. When the canal is getting inhibited, what will get? Resulting a nystagmus beating to the opposite side. That is the healthy side. If the left side is affected, you get nystagmus beating to the right side. Let us see now. Now you put the patient again, lies down. Normally, you can gravitate. When he lies down, what will happen? The ambulatory portion is now much up now. So it's easy for the otoconia to drift back towards backside. Ambulatory end is up. Since the otoconia gravitates away from the cupola, that canal is inhibited. As I told before, and the fluid is away from the ampulla, the canal is inhibited. So you get a pseudo-spontaneous nystagmus squeeze towards the healthy ear. So this is on lying down. This is on lying down test. You get nystagmus B to the normal side. So in geotropic type, on lying down, the nystagmus is to the unaffected side. When the head is pitched forward by 90 degrees like this, now I'm turning the other way around. Instead of lying down, you're bending the head forward like this. The otoconia, what will happen? It moves forward toward the ampulla. Gravity towards the ampulla, stimulating it, causing nystagmus beating towards the affected side. That's a stimulate the affected side. Now, to example, to show this one, I will show another video. Look at this patient now. He's moving toward alignment on the left side. Nystagmus is towards the left side. Again, straight back, supine, no nystagmus. This side, sorry, this is straight back. And turning to the right side. Nystagmus is to the right side. Correct? It seems to be more high amplitude, more toward on turning to the right side. It subsides after some time. Okay, so we're not sure which side is affected, correct? Let us see. Now which canal affected? Any other test to confirm? Now I make the patient is sitting now. I make him to lie down. Sitting, lying down. She's beating to the left side. That shows that the canal affected is the right side. Okay. Canal affected from the right side is the one. It's a very simple technique to do to find out which side is affected. From the previous video, you can say that right side amplitude is slightly higher. You can say possibly right side is affected. But this definitely tells you it is the canal is affected on the right side. Because it moves away from the affected ear. So on lying down from sitting position, the canal with particle gets inhibited since the particles gravitates away from the anteriorly seated ampulla as told before, and this time must switch to the left side. Shows that the canal is affected is the right side. Now another patient with positional vertigo. Look at this particular patient. Turning head to the right side. Right side patient lying on the right side. Nystagmus is towards the left side. Away from the ground. Beating towards the left, away from the ground. Then making it straight. Nystagmus disappears. Turning to the left side. Turning the left side. Nystagmus AB beats away to the right side now beats. It's again meeting towards the right, away from the ground. Here on turn to the left side, it seems to be more. And subsides. Okay. Now let us see that. Now I'll show you which side is affected. Because in apogeotropic type, the side where the nystagmus is less is the affected side, unlike the canal lithiasis. Anyway, let us see the lying down test here in this position. Lying down. It is beating to the right side. Here, the canal affected is the right canal is affected.
So right cupular lithiasis, right?
It's a right cupular lithiasis.
Right lateral cupular.
Right. Supine. So in the case on lying supine, in the case of canal lithiasis, it beats towards the normal side. In the case of cupular lithiasis, it beats towards the affected side. So if it's beating to the right side here, means that in cupular lithiasis, side which is lying down, now beats to the right side. Okay, because you can see on here also turn in the left side, the nystagmus is more. That also point favoring that. But as told before, sometimes difficult to differentiate with. This is a very simple lying down test. You can clearly tell there's no confusion whether it is canal lithiasis, which side is affected, is no confusion. First, find out apogeotropic, geotropic. On lying down, if it is beating towards the normal side, it is canal lithiasis. Is beating to the affected side, that it is cupular lithiasis. So this apogeotropic down, the nystagmus beats to the right, showing the canal affected is the right side. So in apogeotropic type, on lying down, nystagmus beats to the affected side. This again shown in this picture is another way of depicting it. This is the viewing from behind. The patient is sitting. This is the position of the particle here. That's posterior canal lithiasis. Patient is just right supine like this. The nose is up. What will happen? The particles move away from the ampulla. It is moving away from that. So away from that. So that means the canal is inhibited. So you get nystagmus to the opposite side. Nystagmus away from the affected ear. In the case of cupular lithiasis, the attached particle is attached here. You lie supine. What happened? The flow is towards the ampulla because it becomes shifted in the direction of weight. It's become weighted. It become uppermost. It comes down. The flow is in this direction. That is, it is towards the ampulla. That ampulla gets stimulated. So you get nystagmus to the affected ear. That is when cupular lithiasis, nystagmus to the diseased side, whereas in canal lithiasis is to the normal side. Okay. No, in fact, I brought this case just to reiterate our vestibular physiology, so that unless we refresh it, we'll forget. Any questions on that? Okay.
Yes, sir.
Yeah. Shall I go to the next case?
Yes, sir.
Okay. So if any juniors want the copy of the slides, I can send them this animation and all I have created myself with great effort. So it will be over. It will be useful to you to make you understand. If anyone wants that, I can send them by mail or anything. Okay. It's a short case, not a short case, anyway, 15 minutes are there. So the story of a 52-year-old male, old age diabetes mellitus. Again, a case of neuropathy. Came with a history of pricking pain of both feet along numbness on the left sole for the last 2 years. Heaviness and clumsiness of the right hand for the last 3 months. Aching pain of the right arm for the last 3 weeks. Unable to hold objects and buttoning of the clothes and difficulty in writing with the right hand for the last 2 weeks. So, short history, came with history of pricking pain of the both feet, diabetic for long. Then main complaint was he's unable to use his right hand and aching by the right upper limb. That's for about 3 weeks duration. Total duration is 3 months. Now look at, yes, mild wasting of the first two intershade there. Tone is normal. Deltoid normal. Biceps, triceps normal. Wrist section is normal bilaterally. But finger flexors is weak on the right side. It is weak on the left side also, but less compared to the right. Finger flexors were normal bilaterally, but flexor pollicis longus is weak on the right side. That's weak. Flexor pollicis brevis also is weak. Opponents is also weak. Introshare also weak. The left side also introshare very weak. Abducted digitally may be weak. Here the flexor pollicis longus has good power. That is weak on the right side. As told me already. Flexor pollicis brevis is weak on the left side as well. Prominence is positive, bilaterally more prominent on the right side. Lower limb hip flexors are not normal. Dorsiflex is normal, but EHL was weak. That is weak. Flexor pollicis long, hallucis longus was almost normal. Adductor hallucis was weak. Reflexes, upper limb reflexes are all absent. Abdominal reflex intact. Right knee jack is absent. Left is well elicited, but right is absent. Both ankle jacks were absent. Plantar was indefinite. Sensor system, upper lip normal. Touch is normal throughout. Vibration senses normal in the upper limb. It is decreased in the toes. In angle, it is well elicited, well appreciated. JPS is normal in the upper limb. Is said correctly. Feet, it was impaired. Is leaked. Rhombus was negative because the JPS impaired only over the toes. He could walk on heel and walk on toes. So, an examination, its main involvement was that is his complaint also. Wasting of the interosseous muscles, both hands more on the right side. Tone normal in both upper and lower limb. Power right upper limb, wrist flexion, extension, finger flexors normal. Weakness of finger extensors and flexor pollicis longus. Weakness of thenar, hypothenar, interosseous. Adductor pollicis weak. Left upper limb almost same, except that it's got sparing of the flexor pollicis longus and little mild involvement of the finger extensors. So wrist flexion, extension, finger flexors, and flexor pollicis longus is normal. Weakness of finger extensors is less there, but less compared to the right side. Small muscle weakness is there as compared, just like on the right side, but it's less compared to the right side. Lower limb weakness of the EHL and flexor hallucis longus and adductor hallucis. Dorsiflexus and plantar flexus normal. Detail upper limb, biceps, supinator, triceps absent. Lower limb right knee jack is absent. Left is brisk or not brisk, well elicitable. Both ankle jack absent. Plantar indefinite. This is just reflexes again. Upper limbs are all absent. Left knee is present. Ankle absent. Sensory system sensations all normal in the upper limb despite the weakness. Impaired vibration or both toes more on the right side. Impaired JPS or both toes. Other things are not. So, where is a localization and diagnosis?
Vibration upper limb, sir?
Abnormal. Sensory system exam vibration, JPS sensation all normal in the upper limb. Lower limb is embedded only on the toes. Long-standing diabetic. Any thoughts? Am I audible?
Yes, sir.
Yeah, please. Any idea where could be the lesion in this patient?
Anti-Honsel versus peripheral nerve.
Yeah. Okay. Could be anti-tonsil disease affecting the upper limbs, or it could be something like a motor peripheral nerve, like MMCB is one possibility which you can keep in mind, or a motor CADP. Those are the things you keep in mind. Okay, good. And the lower limb may be due to unrelated diabetic peripheral neuropathy, because he has no fresh complaints except for the paining pain in the left foot. No sensory complaint in the upper limb. Okay, query MMCB with diabetic peripheral neuropathy, or motor CADP, or anti-tonsil disease. So this is the NCS finding. Both peroneal not elicited. Probably we are picking from the EDB by part of the peripheral neuropathy. Tibial also is not elicited. The small muscles are affected. Median has got a normal amplitude, but distal is mildly prolonged, mild decrease in the compression velocity. Come to the ulnar now, the amplitude is low bilaterally, and velocity is marginally increased or decreased. Distal latency is normal. Come to the lower limb, both ulnar sensory is not obtained, even though she had normal sensory examination on the upper limb. The sensory potential could not be picked from the ulnar, which are repeatedly checked is not elicited. The lower limb, it is absent, both supratal, peroneal, and sural. Median, it is normally present. F5 latency is both the lower limb not at all elicitable, not record, but prolonged in both median, not elicited in the right ulnar. Left ulnar is also prolonged. What is the diagnosis? You want to see the NCS once again, I can show the NCS. This is the NCS. Look at the median, right median, left median, ulnar. Sensory. Equivalent. So what will you do in this patient and how will you manage? Any thoughts? What will you like to do?
Median and ulnar CMAPs were reduced or normal?
I'll show the median. No, the CMAP is no, sorry. CMAP is with the normal limits 5.2 and 7.5. Mild prolongation of distal latency is a diabetic also. Mild prolongation of mild decrease in the conduction velocity 45, 40. No, can be taken as normal.
Ulnar, there was conduction block 2.8.
Ulnar, there is conduction. Yeah, there seems to be conduction.
Could be a demyelinating thing. Demyelinating.
Okay, could be demyelinating.
Motor is demyelinating. Sensory could be part of peripheral neuropathy also.
Okay, but ulnar potentials are also absent. Okay, so let us look at the clinical picture in this patient once again. Case affected distal muscles in the upper limb, mainly the distribution of ulnar and radial. Now, usually in diabetic neuropathy, when you get upper limb involvement, it speaks against in diabetic neuropathy. It is significant motor involvement. Unless it's the distribution of a carpal tunnel or a pressure palsy or intrapneuropathy like ulnar, which is more common in diabetic. Something like a distal symmetrical involvement of the muscle involvement, including radial, also is very uncommon. Whenever you get that thing away from a simple state for diabetic neuropathy. Neuropathy only uncommonly produces significant weakness of upper limbs, that too without affection of the lower limbs. Usually affection of nerves in the upper limbs that would end up in neuropathy, CTs, and ulnar nerves. Alien muscles are extremely rare. So we have to think of other possibilities like demyelinating neuropathy, is it MMCB or motor CADP or a vasculitic neuropathy. Let us review the NC's result. He has got sensory potential absent, so MMCB is ruled out. So let us look at that. Now let us look at this point once again. What Joy has picked up is correct. He has got a conduction block in the ulna now. But even before that, look at this point, very often we overlook. See, look at the FA latencies. See, this is the FA latency which is shown here and the conduction parameter. Look at the median FA latency is grossly prolonged from 31 to 37. But look at the distal latency and the conduction velocity, very minimally prolonged. Okay, so that mild increase in the distal latency and mild increase in the conduction velocity cannot explain such a prolongation of the FA latency. Simply look at the left ulna now, 38. But here, the distal latency is 3.4, almost normal. Velocity is also normal. Conduction velocity is also normal. So despite relatively normal distal latency and relatively normal conduction velocity, you get a markedly prolonged FA latency. So that should ring a bell. Think that it is not a simple straightforward case of neuropathy. You have to think of a proximal demyelinating disease. So even if you don't see the conduction block, which you have already picked up, so FA is unduly prolonged. Now the other point, as Joy has picked up, see, he has got a conduction block in both ulna. Why the sensory potential is absent? Because he must take a distal conduction block. That is why sensory potential also is absent. See, his amplitude is 2.8, that is less. That means the demyelinating lesion is maximum distal to that also. So there's a possibility that you can have an absent sensory potential. Conduction block in the ulnar nerves. So in fact, I seeing this demyelinating picture, I asked him to come for admission, but somehow or other he did not come. He came after 6 weeks, repeat conduction was done. Again, the same thing. Radial was also, the NC's parameter is almost the same, little worse than before. That's all. The sensory, everything is normal. So always look at the waveform to diagnose demyelination. So look at the waveform. It's quite dispersed potential. The duration is not that much prolonged, mild prolongation, but this is dispersed irregular potential. So if you get a decreased CMAP amplitude, always make it a point. Look at whether the waveform. So this is a typical demyelinating pattern. Again, you see the ulnar nerve, the dispersed potential. This is radial, which is no dispersed potential. Right radial, okay. Left median is no dispersion. Right median, mild dispersion. So, this is the point which I brought the case was superficially may look like a motor neuron disease, more like a motor anticonceptual disease or conduct MMCD. But look for the dispersed potential and compare the FA latency with the available distal latency and conduction velocity. Disproportionately prolonged FA latency, always consider this possibility in mind because there may be proximal demyelination. So anti-glycosyl antibodies were done, which is negative, negative, ANA profile negative, sugar 63, and CSF. And patients put on IVMB. I don't know, you will not believe. Within 3 days of IVMB started improving. He said, sir, I could write now, which I was not able to write before. I could eat my food. Within 3 days. He started improving within 3 days starting IVM. So that's the lesson I have to take here. Okay, any questions? He's a diabetic, still I put the patient on IVM.
Sir, any diabetic who comes with motor weakness, one should always think of demyelinating disease and
Yes, yeah. Please, upper limb always you should be very careful. Think of demyelinating neuropathy or some other problem. It is not a straightforward diabetic. So you must see any number of diabetic neuropathy. They all come with lower limb findings, sensory loss and motor weakness. Upper limb involvement is either due to carpal tunnel or some other, and rarely end up in neuropathy. Significant upper limb weakness is hardly ever you find in diabetic neuropathies.
Sir, but distal or upper limb wasting can occur in the cervical plexopathy also of diabetes, no?
Yes, you can have definitely. Just like our lumbosacral plexopathy affecting the diabetes, they use the commonest is lumbosacral, thoracolumbar plexoradiculopathy. It can also affect the cervical amyotrophic nerve in the cervical plexus. It may be upper station or middle station or lower station, but distinctly uncommon, and they present unilaterally like that. They present not like the one which is presented now.
Whether it is proximal or distal more.
It can be both. Yeah, it can be both. That's depending upon, it can have distal, it can have proximal, all can occur. Usually it's proximal, just like our lower limb. Sometime I can show you a case of a diabetic amyotrophy confined only to the distal muscle producing conferon like pattern distribution without sensory. But that's uncommon. In most of the diabetic amyotrophy affect the proximal muscles, in about 50% of them, they can have associated distal muscle also, usually in the conferon distribution.
Sir, how long do you generally continue with oral steroids after IVMP in diabetics?
In diabetic amyotrophy, give only 3 or 5 injections stop. No long-term steroid. Most of them will get better with that. I do not continue with the long-term steroid. But CADP, I will continue. Like this, you have to continue. I'll continue with the oral steroid and put them on mycophenolate. Pardon?
That goes case to case, how long you continue?
Cases like this?
Yes.
Yeah, I put them combined with this patient, I put them on mycophenolate as well as steroid and continue both till the mycophenolate takes its effect about 2 to 3 months, then continue with steroid and gradually taper steroid, but you continue only on mycophenolate.
Yes, thank you, sir. Thank you. Exactly.
This patient CSF was normal, sir? Protein?
CSF was mild elevation of protein, 68, 63.
In diabetic plexopathy, if the patient does not improve with IVMP to his, satisfaction, would you
correct.
try something else after some time?
They do improve, but they take some time. Suppose you give IVMP, they will not improve immediately. The pain subsides remarkably well, but the weakness will take time, take months for improvement. Ultimately, I've seen severe weakness, they also improve over a period of time. As long as 1 year it may take for the improvement to occur, provided it is a proximal muscles which are affected. Those diabetic amyotrophy which affect the distal muscles like the foot drop, they do not improve very much. They are often left with sequelae, even after years. But the proximal muscles, almost all of them do improve in many of these things.
Can you try some other immunosuppressants if the patient is not improving, say, within 6 months?
You can definitely try IVAG, the patient can afford, you can try IVAG. So these are, in fact, there is actually no robust literature support for either steroid or IVAG. But we have found it's effective, and I think Butch also knows that we has also tried many patients on IVMP. He found it to be effective.
Yes, sir.
Yeah.
And Butch, you were telling that in lateral canal BPPV, you try those maneuvers for the treatment. You take the patient first to the side where the nystagmus was less, like, even if it's scapulolithiasis or canal lithiasis.
Yes, because ultimately, even if you go by the entire theory, it turns out that the side which is less is the side where you do the Guffoni. So the side is
the
less. So side in canalolithiasis, you do the Guffoni to the non-affected side. So where the nystagmus is less. In canalolithiasis, you do the Guffoni to the affected side, where the again the nystagmus is less on that side. So ultimately, if you do it on the side where the nystagmus is less, you will be right, whichever it is.
That's a shortcut way of remembering. It is a good thing. Need not think about the physiology of the pathophysiology of this thing.
Yeah, it helps
in
in a
terms
busy
of
OPD.
it. Yeah, correct. Okay, then shall I close?
Thank you, sir.
Thank you. Good night.
Thank you,
Good
sir.
night.
Thank you.
Thank you, sir. Thank you very much. Good night.
Thank you. Good night.